The next particle is photon, which is very familiar in radiation therapy for 100 years, but in this case, it is targeted in a new way. And we will hear a presentation from Dr. Anna Brunzel from University of Amsterdam Medical Center.
Thank you. So good morning, everyone. First, I would like to thank the organization for the opportunity to give a presentation here about clinical applications of MR-linac in radiotherapy. These are my disclosures. So these are the topics I would like to look at today. First, I will start with a short introduction about online adaptive MR-guided radiotherapy. Then I will show you our routine workflow for adaptive MR-guided SABR in pancreatic cancer. I will discuss some clinical outcomes of MR-guided SABR for adrenal metastasis and for prostate cancer. And finally, I will show you a way to perform MR-guided radiotherapy for kidney cancer. So we perform online adaptive radiotherapy using the Meridian. And we decided to make use of all capabilities of these machines for all fractions in all patients. And that is MR-guided tumor setup, routine plan adaptation, and gated delivery using small margins. And we use the machine in the form of SMART, stereotactic MR-guided adaptive radiation therapy. Our center focuses on demonstrating clinical and dosimetric benefit of particularly daily plan adaptation. And here you see our routine workflow for online adaptive SABR for a variety of clinical indications, and now with the focus on pancreatic tumors. So briefly, after consultation, a simulation MR scan is performed in breath hold. Treatments are preceded by a repeat MR scan acquired in breath hold, and this is followed by a rigid co-registration to the GTV on the pre-treatment MR scan. The next step is to deform and recontour the organs at risk within 2 centimeters of the PTV. And after calculation the baseline plan on the new anatomy, all fractions are re-optimized. After a fast QA, treatment is delivered using gated breath hold delivery. And as you can see in this figure, part of the workflow runs parallel. The close proximity of the organs at risk in pancreatic cancer poses a challenge to SABR delivery. And that is why pancreatic tumors are ideally suited for online MR-guided SABR. There is a clear indication for daily plan adaptation, as you can see in this example here, where the organs at risk, in this case the bowel, can change substantially in between fractions. And in these lower graphs, you see this effect for 25 patients with pancreatic cancer. After a daily setup on the GTV, there is a large variation on both the volume and the position of the adjacent organs at risk. The main principle for SABR is that the high-dose region around the PTV is what matters most for toxicity. And we developed a planning procedure that was developed using rings up to 2 cm around the PTV, and only part of organs that are within these rings need to be adjusted to the anatomy of the day. And for pancreatic cancer, optimal organ sparing prevails over target coverage. The adaptive process needs to be fast and feasible while the patient is in treatment position. After manual adjustment of the GTV and the organs at risk, the position and the volume of the partitioned organs at risk guide plan reoptimization. In this way, the steepest dose gradient is there where you need it for the anatomy of the day, as you can see in this example from baseline plan to the first fraction. The RMRT plan is reoptimized, and after a fast QA, delivery is performed. Here you see an example of a patient with pancreatic cancer for whom the benefit of daily plan adaptation is clear. with an improved coverage of the target and improved sparing of the organs at risk indicated by the dotted line. And results for a group of pancreatic cancer patients also show this dosimetric advantage of daily plan adaptation. And of course, it is important not only to quantify the average dosimetric benefit, but also to identify patients with pancreatic cancer who benefit from daily plan adaptation or not. Adaptive planning was assessed for 180 fractions by comparing non-adapted plans with re-optimized plans using GTV coverage and high-dose organ at-risk constraints. And decision tree analysis was performed to identify subgroups that are likely to benefit or not from this routine plan adaptation. It was concluded that there was a benefit in approximately half of the fractions by improving target coverage and organ at-risk sparing, and it appeared that plan adaptation was relevant mainly in cases where the distance between the GTV to the organs at risk was 3 millimeters or less. So translating a dosimetric benefit of adaptive MR-guided radiotherapy in a clinical benefit, in this multi-institutional phase 2 trial, 5 fractions of 10 gray were evaluated using on-table adaptive radiation therapy. And adaptive SABR was performed in almost 90% of all delivered fractions. And their primary endpoint was met, and there was a reduction from historic comparison of 15.8% to 8% in grade 3 toxicity rates at 90 days. So this trial, together with more retrospective and prospective trials, demonstrates that a dosimetric benefit of adaptive MR-guided SABR can be translated in a clinical benefit for patients. Regarding the effectiveness of MR-guided radiotherapy, the more mature results of this study showed a high local control at 2 years of almost 80%, and again, a low rate of late grade 3 or higher toxicity. During treatment, gated breath hold delivery is performed in all patients with upper abdominal and thoracic lesions. And we developed the patient feedback system where the patient can actively help with his own treatment and breath hold. And this is performed using a pair of glasses and a mirror and a monitor at the end of the meridian. And here you see an example of what patient actually sees during treatment. As for treatment delivery, motion monitoring is conducted using real-time MR imaging. And the projected GTV in red is tracked on a feedback monitor. The step and shoot IMRT technique is delivered in 5 fractions with the beam on only when the target is inside the PTV in red, which is used as gating boundary. This figure shows the total smart duration per fraction for different indications. And on average, this was 54 minutes. And now, after upgrades and experience, the time per fraction is between 25 to 40 minutes. And this pie chart shows the average duration of the different components of smart with gated breath hold delivery. A bit more than 1/3 of total time is the adaptive part of the treatment. To better map the role of adaptive SABR in pancreatic cancer patients, we initiated several studies in the last years, also to evaluate the role of adaptive MR-guided radiotherapy more, and that is in the LabStar study. All patients with locally advanced pancreatic cancer that are not eligible for tumor resection after initial chemotherapy or have isolated tumor progression or are unfit for surgery can be included in this multi-center phase 3 LabStar study. Eligible patients can be randomized to the intervention, 5 fractions of 10 gray with MR-guided radiotherapy, or the standard of care arm with chemotherapy and best supportive care. And the aim is to investigate the efficacy of ablative MR-guided radiotherapy on health-related quality of life. So in the following slide, I will show you some clinical outcomes for adrenal metastasis. Recently, a retrospective multi-institutional pooled analysis evaluated clinical outcomes and toxicities of adaptive MR-guided radiotherapy of adrenal metastasis in more than 250 patients. And these patients were treated in a period of 7 years with a median BED of 100 Gray, and almost 90% of fractions used adapted plans. Although not statistically significant, no local recurrences were observed after treatment with a BED of more than 100 Gray, with a single fraction or with a dose per fraction of more than 10 Gray. More than 1/3 of the patients showed a complete response during follow-up, and there was, on multivariate analysis, a significantly higher overall survival in patients achieving a complete response and in patients in a good condition. And there was grade 3 toxicity or higher in only 2 patients. So it was concluded that these results indicate that adaptive MR-guided radiotherapy represents a new standard of care for adrenal tumors. And I would like to share this case with you, a lady of 74 years old, and she was suffering from metastasized non-small cell lung cancer. And she was referred to our department because of oligoprogressive disease of bilateral adrenal metastasis during her treatment with capmatinib. And here you see her treatment plan with the intention to treat both lesions in one plan, 5 fractions of 10 Gray. And it is possible now to see both lesions separately during real-time MR imaging on a sagittal plane, and the corona plane we can use during tracking to see both lesions. In the following slides, I will discuss some outcomes on MR-guided radiotherapy in prostate tumors. The first study worldwide, the first phase 2 study worldwide, investigating the clinical benefit of SMART on toxicity and quality of life in patients with localized prostate cancer, was initiated at our center. A clinician reported side effects, grade 2 or greater, were highest at the end of radiotherapy. And during follow-up, the grade 2 or greater GU toxicity remained between 3 and 5%, and there was no GI toxicity observed. And I have addressed 2 important questions regarding patient-reported outcome. After 12 months, there was a relevant limitation on daily activities due to urinary symptoms reported by no patient, and 2.2% reported a relevant impact on daily activity due to bowel symptoms after 12 months follow-up. In a recent review and meta-analysis, acute GU and GI toxicity rates were compared between MR-guided SABR and CT SABR. And they included prospective trials evaluating prostate SABR with a sample size of 10 patients or more, a fraction scheme 4 to 5 fractions to a total dose of 35 up to 40 Gray, and with documentation of acute toxicity rates. So there were 2 groups: MR-guided adaptive SABR treatment, defined as treatment on an MR linac with daily online plan adaptation, and CT SABR treatment with cone beam CT and or fiducial-based image guidance techniques. Finally, 29 prospective studies were included with more than 2,500 patients. There were more high-risk patients and therefore a higher use of ADT in the MR group. So the MR group was with daily online plan adaptation, but between the 2 groups there was no significant difference in PTV margins used or in low use of rectal spacers. The MR-guided adaptive SABR is associated with significantly reduced risk of acute grade 2 or greater GU and GI toxicity. And they stated that further investigation is needed to pinpoint the specific underlying causes, especially the part of the daily online adaptive planning. And of course, I would like to look into the results of the only randomized phase 3 Mirage study, where they used aggressive PTV margin reduction from 4 to 2 millimeters with MR-guided SABR, compared it with CT SABR, 5 fractions of 8 gray with no daily plan adaptation, and the primary endpoint was the incidence of acute grade 2 or greater GU toxicity. A pre-specified interim analysis was performed after 100 patients were evaluable for the endpoint, and the incidence of acute grade 2 or higher GU toxicity was significantly reduced in men receiving DMR treatment. So a revised power calculation was performed, and it was concluded a conditional power of 89% could be maintained with only 154 patients, and therefore the trial was closed to accrual early. And again, the 90-day endpoint showed that the grade 2 or higher GU and GI toxicity was significantly lower in the MR group. After 1 month, some patient-reported outcomes were significantly lower in the MR group. For example, there was a lower rate of large increase in IPSS. However, this was not observed after 3 months. So it was concluded that the PTV margin reduction afforded by MR guidance resulted in the observed reduced acute toxicity risks. And I would also like to mention the Hermes trial. This is a single-center study in intermediate to high-risk prostate cancer patients, and patients are allocated to a 5-fraction scheme or a 2-fraction scheme with a focal boost using MR-guided adaptive SABR. And the primary endpoint is the cumulative incidence of grade 2 or greater toxicity from start to 12 weeks post-treatment. And they performed an interim analysis after 10 patients. And as you can see here, the grade 2 toxicity in the 5-fraction scheme was 10%, and in the 2-fraction scheme was 20%. So this interim analysis has shown acceptable toxicity rates, and recruitment will continue to completion. Well, actually, radiotherapy was not part of the treatment in primary kidney cancer. However, this is slowly changing. The most recent guideline on renal cell carcinoma of the European Association of Urology mentioned for the first time stereotactic ablative radiotherapy as alternative to surgery. However, they say more evidence from randomized trials is needed. So a few months ago, the promising clinical outcomes of the Fast Track 2 study were published. And this is a multi-study trial that was designed to demonstrate the efficacy of SABR in patients that are not operable or have high risk for operation. And the primary endpoint was met, a 1-year local control of 90% or better. And at a median follow-up of 43 months, the cancer-specific survival and the local control rate was 100%, with an acceptable toxicity profile. So in the absence of evidence of randomized trials, this is the current situation in our region. Prior to 2016, SABR was not part of the treatment for patients with primary RCC. And nowadays, after joining and investing in the multidisciplinary tumor board, SABR is a valid option for patients with primary renal cell carcinoma. And the choice of treatment strategy discussed in our MTB is dependent on patient and tumor characteristics, as well as on patient and physician preferences. And several factors are included in this, such as the residual renal function, the comorbidity of the patient. So tailoring treatment for a specific patient and SABR is an option. And here you see some reasons for SABR referral. So what kind of patients are referred from other Dutch hospitals to our center? For example, this 73-year-old lady with a pathology-proven clear cell renal cell carcinoma with an impaired renal function. And there was an indication for radiotherapy, so they performed a 4D CT for simulation. However, due to the motion, location, and the impaired kidney function, she was referred for stereotactic MR-guided radiotherapy. So in this group of patients who often have an impaired renal function, the management of respiratory motion is important, and this can be measured with the 4D CT and managed through the use of an ITV. There is a dose-response relationship observed between the dose delivered to the non-tumor kidney and the subsequent decline in kidney function. So sparing functional or non-tumor kidney from high doses may help reduce the risk of functional loss. Compared to free breathing and the use of an ITV, employing advanced motion management such as respiratory gating and breath hold will lead to smaller treated volumes and thereby dose reduction to non-tumor kidney. And this figure illustrates the nephron-sparing effect of gated breath hold delivery. On the left, you see the target volume without breath hold. On the right, with breath hold. And here you see normal part of the kidney that would have been irradiated without breath hold. So back to the case that was referred to our department, she was treated with 5 fractions of 8 Gray using gated breath hold delivery. And here you see that motion monitoring was conducted using MR imaging in 2 directions during delivery. And this 78-year-old male patient was, in my opinion, the ideal patient to perform the next step in MR-guided SABRE. He has a small tumor in the lower pole of his left kidney, so no organs at risk nearby. And he arrived at our department for a single-day plan and treat. And here you see the flow chart that was drawn in advance with expected times for each step. And during the one-stop shop, we were able to save time. So less time was required for the contouring and also for the treatment planning. And that was because we did already some preparations. So the single fraction of 26 Gray was in 54 minutes. And the total duration of the whole procedure, so the single-day plan and treat, was in 2.5 hours. So online adaptive MR-guided SABRE for pancreatic tumors improves target coverage and decreases high doses of the organs at risk, shows a tolerable toxicity profile and a decrease in incidence of acute toxicity, shows high local control rates, and there are several ongoing studies. And for the prostate tumors, online adaptive MR-guided radiotherapy is associated with a significantly reduced risk of acute grade 2 or higher GU and GI toxicity. However, a longer follow-up is needed to evaluate late toxicity and disease control outcomes. And there are studies ongoing, also the feasibility of ultrafractionated radiotherapy. And for the adrenal tumors, the online adaptive MR-guided SABRE obtains high local control rates and is a well-tolerated treatment with low toxicity rates. For the kidneys, also MR-guided SABRE has several advantages that can be used, for example, the gated treatment delivery, but it can also be used as a single-day plan and treat for most of the T1A kidney tumors, so this may be a serious competitor for thermal ablations and also for partial nephrectomy. And with that, I would like to thank you for your attention.
Thank you, Anna, for this excellent talk. So we all know that there is a huge need to improve the outcomes for pancreatic cancer. So with the data that you just presented, and what is your opinion and what are your standards at your own hospitals or recommendations for the hospitals who have that kind of magnet guided equipment in their use. So is time ready to recommend preoperative MRI-guided radiotherapy for pancreatic cancer?
So for pancreatic cancer, we have a lot of studies. I think we really need to prove the benefit of SABR for pancreatic cancer in studies. So we have a lot of studies in the chemotherapy in locally advanced pancreatic cancer patients, but also preoperatively. So we will start a study where we combine chemotherapy, immune therapy, and SABR in borderline resectable pancreatic cancer patients. So I think if it's possible, you should treat patients in a study for pancreatic cancer to prove that SABR is a valuable option.
And then at your institution, how many percentage of the patients receive treatment as standard therapy, or are you including all patients in the clinical trials with your MRI-guided device?
Yeah, I think so. We have our standard. We treat our borderline resectable pancreatic cancer patients with chemoradiotherapy. That is the standard. But for now the study, we investigate whether SABR is a good option, and so there will be a kind of if patient wants to join the study, he can participate in that study. And for the rest of the patients, I think we treat more than 80% in study. Yeah.
So other questions?
I have one question. We have been learning to use MR-Linac in our institute for 1.5 years now, and when you show the example of prostate treatment, our experience has been that it's not the easiest target for adaptation, because if the adaptation process takes too long, then the bladder fills and you need to do the adaptation again. So how long time are you using for adaptation in this case?
Yeah, so for the prostate cancer, we now have time slots for 30 minutes, and most of the time we finish within 25 minutes. I think it is experience, and my colleague always said, don't pixel, really be, try to be fast. And then you don't have, well, we rarely see the problem of the filling bladder. And maybe that is because we always ask patients to come and empty their bladder and then drink 2 glasses of water and then start the treatment.
Then there have been a question if the MR-Linac should be equipped with high field or low field MR. And there have been 2 different equipment in the market. What do you think? Are they competing against each other, or do they have just different properties with different applications?
Well, so I think for the use of radiotherapy, what do you want as a radiation oncologist? You want to see the target and the organs at risk, and you can see this properly with the meridian, so with the low field MR scan. And I think with the Unity, you have different options, so you can use the diffusion weighted images, and that is something we don't during our practice.
So if there are no more questions, we thank Anna.